Well, welcome everyone. I am Michael Morella, Managing Editor of Events at US News and World Report. Thanks so much for being with us for today's webinar, Community Health Justice for All, Ensuring Equity in Care Delivery. Today's session is the latest webinar in our Community Health Leadership Forum virtual series, where we spotlight solutions about how health providers, businesses, educators, and others can work together to improve the well-being of their communities. You can learn more at usnews.com/events. Before we get to our panel, I just want to share a couple of quick notes. We are capturing video of today's session, and we'll be making that available to those who registered. Look for a follow-up email from our team. We are also simulcasting this session on the US News Facebook page. If you have questions, we encourage you to please type them into the Q&A feature in Zoom on your screen. We'll try to cover those as we can during the course of the conversation. So now I will briefly introduce our panelists who we're thrilled to have with us today. They are Dr. Alicia Cole, System Vice President of Population Health Innovation and Policy at CommonSpirit Health, Marissa Mckeever, Director of Government and Community Affairs for Sibley Memorial Hospital in Washington, D.C., Dr. Mary O'Connor, Chair of the Movement is Life Caucus, Chief Medical Officer and co-founder of Vori Health, and a Professor Emerita of Orthopedic Surgery at Mayo Clinic, and Michelle Matthews, Senior Vice President of Purpose-Built Communities. Welcome to you all. Thanks for being with us. And now I will turn it over to Joe Williams, Senior Editor at US News, to lead the discussion. Joe?
Hi, thanks, Michael, very much. And thanks to everyone for joining us, especially our illustrious panel. We're going to have a great discussion today to talk about delivery in healthcare and making sure that equity happens in that space. And it's a privilege to talk to these fine professionals, and I hope you'll get a lot out of the discussion. And with that, let's get started. With a brief remark, it's an undeniable fact that being Black is hazardous to your health. For decades, you could pick any category from cradle to grave: childhood obesity and hypertension, adults dying from cancer and heart disease, overall life expectancy, and even suicide. And you'd find African Americans doing more poorly than whites, sometimes 2 to 3 times as worse. Then 2020 showed up. The murder of George Floyd, a year ago to this day, ignited a racial justice movement. Those protests and a pandemic that hit Black communities and communities of color harder than white ones made it plain that, like smoking in 1965, air and water pollution in the 1970s, and HIV/AIDS in the 1980s, racism and the effects of it are a public health crisis. And the American healthcare system hasn't exactly risen to the challenge. Consider, African Americans are far more likely than whites to be uninsured, just partly because several states refused to expand Medicaid. A decade after Obamacare became law, 30 million people, 30 million, still don't have health insurance. About half of those people are people of color, and almost all of them live in the South. During the pandemic, African Americans became infected with coronavirus and died from COVID-19 at nearly twice the rate of whites. Black Americans have the fastest growing rate of opioid deaths in the country, and mortality for Black women and babies are the highest in the world, and nobody really knows why. Sidebar, imagine the reaction if white women were dying during childbirth at the same rate as Black women. I'll give you a moment for your head to explode. Then there was the case of Dr. Susan Moore, a veteran caregiver hospitalized with COVID-19. In a viral video she made from her hospital bed, Dr. Moore said the white doctor that was treating her for COVID-19 downplayed her symptoms, ignored her complaints of pain, and didn't want to give her medicine. He also suggested that he was going to discharge her shortly, and he did. 3 weeks later, she was dead. Dr. Moore's death sparked action. Some hospitals cranked up the implicit bias training for caregivers. Others scrambled to hire equity officers to address health disparities in surrounding communities. The Black and white health divide is front page news, and Michael Bloomberg donated $100 million to 4 historically Black medical colleges. But at the same time, public hospitals, from Unity Medical Center in Washington, D.C. to Martin Luther King Jr. Hospital in Los Angeles, they're constantly struggling to keep the bills paid and to keep the lights open and we keep the lights on and the door open. Remember those 30 million people I mentioned earlier? Many of them depend on public hospitals for primary care as well as emergencies. And that's without even getting into parks, access to parks, access to quality, affordable housing, and exercise programs that people of color and that people who are working class can actually afford. So now that healthcare delivery is on the table, what does it mean to deliver healthcare equitably? Is it a matter of ensuring everyone, regardless of employment or income? Does it mean shoring up community hospitals? And if so, how does that happen? Do we need more Black doctors, or should white ones be involved in anti-racism training? And what about housing and park access and clean water and air? All of those are factors. In short, after 2020, what comes next? So with that, I'd like to welcome our panelists and get the discussion going with a brief round of introductions. Let's start with Marissa. Marissa, tell us about your work in this space and what you have in mind for the future.
Thank you so much for having me here. I'm excited to be here with you all today and engage in this very important discussion. My name is Marissa Mckeever, and I manage government and community affairs at Sibley Memorial Hospital, which is a member of Johns Hopkins Medicine. I think a lot of you all are familiar with Johns Hopkins Medicine and our enterprise in this region, Washington, D.C. and Baltimore region. Sibley specifically is situated in Washington, D.C., and actually sits in one of the most affluent areas in D.C., one of the most affluent neighborhoods. So a huge part of my work and the extraordinary team that I get to work with every day has been around over the past several years since our integration with Johns Hopkins. It's really been focused on how are we redefining our community engagement? How are we stepping out of this very well-resourced neighborhood, the very well-resourced patient population that we serve and our surrounding communities to think about what does our community investments look like in some of our most historically disenfranchised neighborhoods in DC? What does that mean for us as a deliverer of care, as an anchor institution, but then also just as a neighbor and a partner that is prioritizing advancing equity? So I'm excited to be here with you all today and look forward to diving in.
Well, tell us, Dr. Cole, let's go to you. You're an equity officer of the type that I mentioned, and your purview is kind of in the same jurisdiction. Tell us what it is that you specialize in and how you get it done and what it means, more importantly, to delivery of equitable healthcare.
Thank you, Joe, and thank you to everyone on this esteemed panel. Really looking forward to this amazing conversation. So I'm a practicing family medicine physician. I chose family medicine because I wanted to be in a specialty that was focused on community, that was focused on helping and serving those across the entire care continuum. And I was committed, having grown up in, west side of Dayton, Ohio. Grew up in an area that many may consider underserved. That's who I wanted to care for. And so my entire clinical practice has been devoted to caring for vulnerable populations, whether that's been rural, urban, et cetera. I joined CommonSpirit almost a year ago to date because of its mission to care for the vulnerable. For those who may not know, CommonSpirit is the strategic partnership of Dignity Health and Catholic Health Initiatives, and that combination actually made us one of the largest nonprofit healthcare systems in the country. And so we are in 21 states. We serve a very broad geographic distribution, and we're a fully integrated network. So we, care for everyone from cradle to grave, right? And so the fact that this organization was committed to serving the vulnerable to the point that it's actually in our mission statement, it really drew me. But part of my role, which is a new role in the organization, is to help our organization move from embedding it in our mission and our vision, embedding it in our strategy, embedding equity in our strategy, which we have done, but now moving into operationalizing equity. And I think that's something that we really need to be intentional about. There's one thing to say we're now woke, right, about these disparities that have existed, quite frankly, for hundreds of years. We all could have predicted how COVID was gonna, those of us who are doing this work and have been doing this work could have predicted that this was gonna be the path of COVID because it aligns with any other chronic medical condition that you can think of for the most part. So how do we start moving beyond strategy and into execution? And that's really what I'm excited to be a part of, leading with amazing colleagues and teammates across CommonSpirit Health.
Mm-hmm. And Mary, your turn. Tell us about your work in this space at your organization.
Thank you, Joe. So like Dr. Cole, I am a physician and orthopedic surgeon, and I've had the honor to chair a coalition called Movement is Life, which is a national multi-stakeholder coalition really focused on eliminating musculoskeletal health disparities. And we really see musculoskeletal, which for those that may not be familiar with the term, refers to joints and bones and muscles, as a true public health crisis. And I just want to walk through a couple images with our participants to illustrate how important movement is to overall health. And when people aren't moving, it really sets them up for other medical conditions and the complex interplay that we see that results in a lot of disparities. So if I could have that first image. So we call this our medical vicious cycle. And you can see it starts with joint pain, which is incredibly common. I mean, most people have joint pain, and arthritis in the older population, which I mean is like over 50 now, which I'm very sensitive to because I fall into that age category now. So joint pain results in lower mobility, which means lack of physical activity, but we're still eating the same. So someone gains weight, and that added weight puts more pressure on the joint. And you see this cycle that's created that ultimately results in bad arthritis, and someone ends up needing joint replacement surgery.
At a very early age, yeah.
Yes, but that's not the full story, because we know with obesity and limited activity come the development of comorbid conditions, heart disease, diabetes, hypertension, and depression. And the key to breaking this cycle is movement, right? Because movement helps our joints stay healthy, helps us keep our weight down. It's good for our heart. It's good for our blood sugar. And so when we look at this cycle, we know that I call this an equal opportunity employer. Anyone can get trapped in this vicious cycle. An affluent white male CEO can get trapped. A poor woman of color can get trapped. But we know that women and individuals of color are much more likely to get trapped in this cycle. And the next image is going to help explain why that is, because surrounding this medical vicious cycle is what you see is a green ring of social determinants of health. And so we know, for example, zip code influences life expectancy. Zip code influences how likely you are to get trapped in this cycle, because where you live influences your ability to go out and safely walk in your neighborhood, just as one example. And surrounding those social determinants are public and private policies related to how we pay healthcare providers, related to, Joe, your comment about, are we expanding Medicaid in certain states to provide better insurance coverage? And then, unfortunately, I had to also add another ring around this, which was pandemic, because we see the influence now of the pandemic and policy, and all of these things come together to promote and create health disparities. And this gets back to my initial point that movement is so important, and really focusing, thank you, Michael, we're done with the slides, focusing on the importance of improving our level of physical activity in our communities, particularly our underserved communities, which is both urban and rural, because we know that there are plenty of disparities in rural America as well as urban America. So I'll pause there. That's just a brief introduction to Movement is Life. I also serve as the Chief Medical Officer for Vori Health, which is a new medical startup. And we're very focused on equitable health care and really changing the delivery of musculoskeletal care to be focused on the whole person, and really a biopsychosocial model and not siloed, fragmented care that so often occurs in our traditional setting. So I'll pause.
Right. Well, that's quite an eye opener, that graphic, and makes me want to start walking a lot more.
Good.
Michelle, tell us about your work. You're in Atlanta. Give us the overview.
So thank you so much for allowing me to be on this panel, and I'm excited for the conversation. I work at an organization called Purpose-Built Communities. We're in Atlanta, but we have a network of local sites across the country. I like to say from Tallahassee to Tulsa, from Syracuse, New York, over to Houston, Texas, and down into Florida in West Palm and Orlando and a number of other cities. And before I share a little bit about what Purpose-Built does in terms of helping local communities build health, I want to just take a moment to share a little bit about what we believe that influences what we do. And I think as we were thinking about this, prepping for this call or prepping for this webinar, this whole idea, and you talked about it, Joe, of health equity and health justice. We believe in both of those, health equity as the process and the opportunities that people have, I like to say, for living their best life. Do people have opportunities for healthcare and all those things that you talked about, Mary, that speak to social determinants of health? Can they move past those into a healthy life? And health justice for us is around not only having access and opportunity, but can you actually live in that space where you are the healthiest you could be? So since we believe in that, and we look at the research, that neighborhoods are a fundamental component of health. And so that's where I come at it. I'm not a doctor, I'm not a part of a health organization or a health system, but we're in the health business because we know that neighborhoods and zip codes many times determine people's trajectory of their health, but their outcomes in life. Mm-hmm. These were not things that just happened. One of the things that you can look at behind me, we were talking a little bit about this as we were getting ready to go on. This is a map of redlining in Atlanta. We know that a lot of things have determined physical space in our neighborhoods. Redlining, the Homestead Act, the way highways were built, all these things influence those social determinants of health. So we at Purpose-Built and what we call our network members sit at that intersection of poverty, place, and race. And how do all those things come together that create conditions that are not healthy? And so we work with local leaders across the country to think about what strategic investments, whether it's in the physical infrastructure, whether it's partnering with a health system, whether it's thinking about the social cohesion of a neighborhood. How do we work with residents and community members, along with partners, to make strategic investments that really can help break the cycle of intergenerational poverty in a way that people can have increased health outcomes that are much more positive, that we can see more racial equity in the spaces in which Black and Brown people and other people of color inhabit, and that we can also think about how we can just move families forward in a way that are positive. So many of the organizations that are represented on this webinar are people that we partner in those neighborhoods to being about those strategic investments. And sort of the last thing I'll say before I turn it over is we focus in a very holistic way. And what I mean by that is we think about mixed income housing because there's a lot of research around the housing and affordability. We think about what we call a cradle to college pipeline for education for families within the neighborhood. And we think about community health and wellness, whether that's parks, whether that's food and nutrition. Mary, you talked about movement. And Marissa, you talked about how you engage the community. All those things are a part of our holistic model to move forward. So I look forward to maybe giving some specific examples as we continue on.
Sure. It's been a year since George Floyd was killed. And during that year, at the start of that year, 2020, we had a pandemic going on that slowly emerged that there were disparities between Black and white. And during the calls for social justice with George Floyd, a lot of what you guys have been talking about got integrated into a lot of the protests. People started talking about access. They started talking about income, housing, all these things that seemed disparate at the time, but were kind of focused when Floyd was killed and people demanded justice for his killing. We're a year later. Marissa, tell me how you think things have changed. I mean, have we lost momentum? Are things still going on? Are things still happening? And is it more difficult or easier to get the kind of initiatives that you guys are talking about off the ground?
Well, I think we continue to have a journey ahead of us. I think all of us around this panel today have been moving in this direction over the course of our careers, the work that we do, the work, the passion that brings us to the work that we do. It's unfortunate that it took George Floyd's murder, that it took the disparities that we saw throughout COVID to kind of put a piece of action behind some of the work that we've been doing in these more individualized spaces. I think that we have a huge opportunity now to make a collective, move forward with a collective response around some of these issues that we've been working on almost in silos. I think it will continue to be upon us to think about where are we in our individual spaces, but then where are we as systems within our local areas, within our regions? How are we leveraging our own resources and making moves forward? At Sibley and Johns Hopkins in particular, we made a commitment last summer to infusing equity into our organization and advancing that strategy forward in terms of the way we do business. We put forth a list of commitments that now we are at a point a year later of really needing to move forward in execution and operationalizing of what that looks like. It requires, number one, a look internally. It's really hard to think about what's your investments in advancing equity and addressing racial equity and health equity, what that looks like in the communities that we're serving and across the patients that we serve, without first stepping back and looking internally.
Sure, it's much more difficult to deliver something equitably if your own organization has challenges inside. I mean, a range of people have done that, including U.S. News. So it's not surprising that Hopkins would try to do that internally. But I guess kind of what I want to know is it easier? I mean, has the needle moved, or are we looking at a long haul here that change is going to be incremental?
The needle has absolutely moved. When we think about where this conversation and what this would have looked like a year ago or even 2 years ago, we're having much more robust conversations. There's more people around the table who want to have these conversations, and we're looking at a way to be inclusive as we move forward. I don't think it's going to be any easier. Like I said, we've got a long journey ahead of us to really see that needle shifting, but to see the amount of energy behind the work, it takes energy to drive anything forward. And when I look back and see the commitments that we each have individually made within the spaces where we work, when we look at the collaboration that is around the table at this time, we absolutely have moved the needle. This conversation in of itself is a reflection of where we can head.
Yeah, Alicia, I thought I saw you nodding your head. Do you agree?
No, I definitely agree. I think completely with the comments that Marissa just made around, and you yourself, Joe, around there's been so much movement from the standpoint of recognizing that this is a real issue. How do we put an infrastructure in place to address it? So you mentioned a lot of health equity officers, for example. These positions, our health equity directors are popping up all over the place.
Yeah. But they didn't exist 3 years ago, and all of a sudden
they didn't. And so that's a big step forward. But I do want to caution us in this, and I have to, one of the people I follow, Dr. Lisa Fitzpatrick, I think she's out of the DC area actually. She had posted something a week or two ago around, how do you tell an organization is really committed to this conversation? Have they hired someone in their C-suite, right, that's devoted to this work? Does that person have resources? Are they resourced? Do they have a 6 to 7 figure budget, right, to do this work? So I think there's things around the infrastructure. or I should say, and I think it needs to go beyond that. It can't be this one individual who, if in full transparency, is often a person of color who are coming into these roles, still into a majority institution. And we are expecting them to move this work forward if we're not holding all the leaders accountable to it. And so, for us, it's not just about this one or two or this one, division, small division that's the DIEB, for example, that's responsible for moving this work forward. It's built into the strategic plan and into goals for all leaders. And so I think that's another thing for us to be mindful of, that sometimes it's great that we have these new positions. And yes, that did not exist a year ago, but we also have to think about how we're supporting them to get the work done.
Well, and that brings me to Michelle. I mean, you've got the long view here. I mean, the maps behind your head say so, that this is a problem that's lasted for generations. And we're talking at least 100 years and probably longer if we're just looking at the modern United States alone. We've had multiple civil rights movements. We have multiple civil rights leaders. And yet, I mean, we still are where we are. And we still have a lot of challenges ahead of us. Give us the long view from your perspective. I mean, you're doing the work, you're on the ground. Everybody here is doing the work, but yours, I would take that you have a pretty unique perspective because you're going into some communities and trying to literally transform them in a very tangible way. Give us a long view about what you're doing and how it's affected a year after George Floyd has passed.
Yeah, so I think the long view is around what those ultimate outcomes are. And as you said, it takes decades. So our very first community, which is in Eastlake, Atlanta, started in the 1990s. They started with a public housing community that they've been able to transform into something that has affordable housing and mixed income rental opportunities for people, that we preserve affordability for those residents. We have a very high performing cradle to college pipeline where we started early learning and really help ensure that college students are able to not only get in, but to persevere. And to think about how we bring, into a food desert, a Publix. I use that just as an example to say any of those commitments, any of those investments do take a while to focus on. But what
we're talking, the first purpose-built community was built when? What year?
It started in the late 1990s.
Okay, and so now you're having tangible
results. We see that we have, as I said, a more mixed income neighborhood. That particular neighborhoods had a housing project that was almost 100% Black and brown families that were in public housing. And now we have an apartment complex called the Villages of Eastlake that has mixed income. And there's a lot of research that shows when you deconcentrate poverty, even if changes aren't made in terms of other interventions, you see that health outcomes are stronger and better for families. We have 28 communities that are working with this model. And just to give an example, when you were talking about, does it get easier? It's still a long game, but who can wait 20 years to see there are effects? So as an example, it is, I won't say easier to get philanthropy and to get support, but for example, once COVID started, we were able to secure for the 3 communities we have in Atlanta a grant of about $2.6 million, where we focused on bringing masks and helping the vulnerable population. We did things around digital divides so that students could participate in school. We did a lot around how do we think about learning loss, all of these things that Mary talked about at the very beginning, which are the social determinants of health. We've been able to attract partners, some of which are hospital systems, to help us think about how do we build that foundation to then continue to springboard after we get past what's happening with COVID.
And Mary, that brings us to you. I mean, what are you seeing a year later? What are you seeing in the work that you do? Have things changed? Are they going to change radically? Is it going to be a slow process?
Well, I mean, everyone has commented that, yes, we're moving the needle, but we're not moving it fast enough. I mean, everyone I think here would agree, we're just not moving it fast enough. And, I am such a huge fan of purpose-built communities because we know that health and wellness is influenced, only 11% of our health and wellness is actually related to direct medical care. Now, of course, that's a really important 11%. If you're having chest pain and a heart attack, or you're in a car accident and you fractured your femur, your thigh bone, right? But so much of our health and wellness is influenced by our communities, our environment, our behavior. There's also a genetics component, but we can't control that, right? And do we need to fix the healthcare system? Of course we need to. Do we need to build purpose-built communities? Of course we do. But how do we take actionable steps right now, right? We don't all have the enlightened leadership, I wish we did, at Sibley Hopkins to advance the programs that they've done. And I really hope that becomes a template for many systems across the country. So one of the things that we've done at Movement is Life is we created a community-based program called Operation Change to get into communities and create change now. And we focused on women with knee pain and obesity. And it was an 18-week program, 3 hours a week. And the first week was educational. So there would be a session on nutrition or mindfulness.
Can I beg your pardon, can I interrupt you for 1 second? Was there often the connection made between excess weight and joint pain? Or the education sessions that you're talking about, are they brand new to people, or is it something that kind of confirms what people have already suspected?
Well, there's a spectrum. Some people understand, and they've seen, their healthcare provider has said to these women, you're heavy, lose weight, it will help your knee pain. But typically, these are people who have struggled with their weight, for a long time, and they're not active. They're not physically active for a whole variety of reasons, as we touched on previously.
Right.
So we
created ability, time, job, that sort of thing.
All kinds of factors. So we created these programs, 40 to 50 women each, 3 hours a week, education, movement, something like line dancing, yoga, people could participate at various levels, an hour of motivational interviewing. We also did something, I would say, maybe unique, in that we grouped the women based on cultural backgrounds. So
say more about that.
So we had groups in Chicago. We had a group of African-American women, a group of Latinas. In Kentucky, we had a group of rural Caucasian women. I mean, it just happened that there were enough people that we could cohort them like that. And we piloted that. And that actually allowed us to tailor the educational content to be more culturally aligned with them. So if we're going to have a cooking program, right? The demonstration would be food that they would eat. And anything that you can do to engage people more, to promote positive behavior change is helpful. So I'm just going to briefly share. Our results, I mean, honestly, blew me away. And I know I'm bragging a little bit, but I'm extremely proud.
Brag on. I mean, that's what we're here to share some information.
So 69 in 18-week program, no doctors, no drugs, no injections, no formal medical intervention, 69% improvement in their knee pain, 79% decrease in their sense of hopelessness. Hopelessness, because they're all depressed. 18% improvement in their walking speed. But Joe, the biggest learning moment for me was when we surveyed our participants and asked them, what did you like best about the program? I thought, and I've got my academic medicine hat on, they're going to say, was it our education content? They could get the same kind of education on the internet. Was it the movement? Was it the motivational interviewing? I mean, those were positives for them. But here's what they said. It was the emotional connections that they formed with each other, that gave them the strength to make the positive behavior changes. It was we brought them together and created a community so that they could support each other. We had women say, this program saved my life. And I realized, like, we just need to get into communities. We need all the structural changes that we've been talking about. Of course, we need them, but we also have to do actionable, effective programs now. Mm-hmm. And so we're very much looking forward to getting new programs up and running. We had to take a hiatus during the pandemic, and we're very excited because we know this is a model mm-hmm. that can work and really help individuals. And then, last point, because I could talk about this for a long time, right? Is these women are like the pebble in the pond. I'll never forget one of our women in Chicago. So she shared this story with me. She started to cook one healthy dish in the evening meal for her. And initially, no one else in the family ate any of it, right? Oh, that's her special dish. Then the children started to eat it. Then her husband, who was initially resistant, he started to eat it too. So one woman did influence the health of her entire family. And so when we look at that, how can we find these people that can go and have change extend beyond them, right? We need to be also promoting that kind of work. Mm-hmm. So I am so strong on what we need to do, as Marissa has pointed out, and Alicia and Michelle, is we just need to get back into communities, because communities are where health and wellness begin. It is not in the doctor's office. It is where we live and where we work and where we play. And that has to be a huge focus.
Right. Well, that's amazing. It's quite a striking example. Alicia, I'm not going to ask you to top that because it's going to be really hard, but I want you to talk to me about community. I mean, that's exactly what you do. That's in your wheelhouse. A lot of people who are on the outside, I mean, we kind of get, intrinsically, I guess, we kind of get that environment is a factor. You're doing your work in one of the most expensive housing cities in the nation, and a city that's got probably one of the largest gaps between affluent and poor in the country. I mean, how do you get this accomplished? How do you get those kinds of results? And is it going to take patience? Is it, what is it going to take?
So thank you, Joe, for that difficult question, but a well-needed conversation. So is it going to take patience? Yes, we didn't get here overnight. And so we're not going to get out of it overnight. However, we also need this sense of urgency to help move this work forward. And so, I sometimes even push back on my own colleagues. It's difficult sometimes to tell other physicians or clinic nurses, clinical staff who, we've devoted a lot of our life, right, to training, to education, to take care of our patients on a day-to-day basis. And, we're doing that, around the clock. And it's sometimes a difficult conversation to go in and say, hey, the work that you're doing every day, 7 days a week is only impacting the individual's health, maybe 10%, maybe 15%. But that's what the research tells us. And
but then where do you go with that conversation, though? I mean, you're having this conversation with people and you're saying, well, we are intent on moving the needle. You have that sense of urgency and you're trying to impart that to other people. And in trying to move the needle, where's the conversation go from there? Do people kind of get it? Do the light bulb go off and they come charging out of the examining room ready to take on the world? How does it go from there?
Yeah, so I think the reality is once you have people sit there and actually think about, even in their individual care interactions, well, you're having this conversation with Mr. Smith about his diabetes and he's not well controlled, right? And I have had the opportunity to work with medical students and residents, and they all know, we as faculty, we all have our little quirks, if you will. And so my quirk is I don't believe in using the term non-compliance. If we take anything take that term out of your vocabulary. Patients have barriers, people have barriers to achieving good health. And quite frankly, often those barriers are not within their control. And so, really having my care providers and colleagues think through, well, what are the barriers to that patient having good diabetes control? Is it they're not taking their medicine? Well, why aren't they taking their medicine? Like, you have to really do that motivational interviewing that Mary mentioned and dive deeper. And so that's one of the things that we're committed to is training, our staff, both current staff and also, we just partnered with Morehouse School of Medicine to expand our ability to train more students of color in the healthcare profession and becoming physicians, and making sure this cultural competency, social determinants of health education is consistent across all of those individuals delivering care. So you have to do the education of the staff as well. But the one thing that I will just, to go back to your question, Joe, around how do we really move the needle? One, partnerships is necessary. I have to say, in my previous role, I had an amazing opportunity to partner with Michelle, and, shout out to Renaissance West Community Initiative, which is a purpose-built community in Charlotte, North Carolina. We worked hand in hand, the health system that I was at the time, and really tying those things together. So I love the fact that Michelle has this redlining map as her background. One of the things, if you look at your healthcare utilization, so health systems, we are automatically looking at things like unnecessary ED utilization, readmissions, and especially as we're moving to more value-based care, we're financially responsible. We're becoming more and more financially responsible for keeping people well. So it's really shifting how healthcare systems, how we think about that community engagement. But when you overlay utilization, when you overlay rates of heart disease, rates of obesity, rates of diabetes, guess what? 9 times out of 10, it's going to be the same redlining map that you see behind Michelle there. And so we really have to be thoughtful about the connections of all of these different things. And there has been the moral imperative to do better. No question there. But there's a financial imperative for us to do better in this space as well. And I do think that helps create some of that sense of urgency to move this forward from a partnership standpoint. So partnerships are critically necessary. And then the only other thing I would add, for those of you who know me, is I'm a big data person. We have to be able to show data in a way that truly tells the story and hold each other accountable, right? So when we talk about even partnerships, what are the shared metrics that we are agreeing to? How are we evaluating those metrics, and how are we holding each other accountable? Because you're not going to know you improve something if you're not measuring it.
Yeah, that's very accurate and quite a significant point. I mean, Marissa, I saw you nodding your head when Alicia talked about partnerships, and she was talking about how data and accountability and return on investment actually is a very big factor here. Was it difficult for you to get people inside your organization to buy into this? And when they did, was it a commitment? Did they go all in, or was it kind of nibbling around the edges? Talk to me about that aspect of your work.
That's interesting that you asked that, because as this conversation has gone forward, I'm hearing about pilots and models here and models there that are absolutely amazing examples that can be scaled. And we deployed a similar approach. We had to start small. Organizational change takes time. Cultural change takes time. Maybe I could just step back and give a little context around Sibley Hospital in particular. 7 or 8 years ago, we were not participating with Medicaid with any of our MCO providers in DC. And so, and these were business decisions that were made, historically. But we looked up having integrated with Johns Hopkins Medicine, and we are now seen as a hospital that does not want to care for Black and Brown people in DC, that does not want to care for individuals of lower socioeconomic status. So as I joined the organization, I'm coming into an organization where our brand and reputation is damaged because of a business decision that we made. But also we had to rethink our investments as we began to participate with Medicaid, we are diversifying our patient population, but we also had to build trust and relationships with communities that we've excluded. And so that took a lot of effort, but a big part of that was around our partnerships and developing strategic partnerships with other trusted community-based organizations, but then also residents in DC who've been marginalized by other systems, not just us. And so by starting small, we in 2017, we went out and just listened to community. We used the process of human-centered design to go in and just sit down and listen. And we had over 100 one-on-one conversations where we learned from residents and asked them, what are your needs and hopes and fears? What does a healthy community look like to you? How do you enjoy health in your neighborhood? What are you looking for from a health system or a hospital to do more and do better? And we heard a lot around the social determinants, a lot around access to care. But one thing that stood out the most for us as we made a decision around our next steps is that, Joe, you know this, with the amazing economic change and economic development that DC has been going through over the last couple of decades, with development comes gentrification, with gentrification comes displacement. So one of the things that we heard is that community just wants to be a participant. They want to have a participatory voice in the change that's occurring and be out in front of creating and designing how to be included in the economic development that is occurring. So we started a program called Ward Infinity, which is essentially our immediate response to what we heard from that community listening tour. Ward Infinity is based around the 8 neighborhoods in DC. DC is broken out into wards. So it builds upon this fact that we are DC and infinite change is possible. So we, through a competitive selection process, we bring on and partner with innovators, entrepreneurs, and intrapreneurs who are living and working and creating ideas and solutions in DC's underserved neighborhoods of Ward 7 and Ward 8. This is Southeast DC across the Anacostia River. And we partner with them and use the methodology around human-centered design, which places the end user, whether it's the patient or the community member or whomever, it places them at the center of designing that particular product, service, or solution. So we're investing in ideas and concepts that are coming from communities that we are trying to serve and infusing resources, technical assistance, coaching, and mentoring to help these entrepreneurs and intrapreneurs really bring their concepts to life. And we've been focused around the social determinants. So we've had concepts around affordable housing, food access, nutrition literacy, small business sustainability. This program.
And are you getting these initiatives through a request for call for questions, request for proposals?
That's exactly right. It's through a request for proposals. We've had 2 cohorts of innovators thus far. We actually are in the midst of, we just closed our call for applications for our 3rd cohort. And so this work takes time. It's amazing to sit back in year 3 and be able to see some of the ideas that came out of our first cohort are now coming to fruition. I would just add, and I'll stop, I'll add that as we invest in these different community partnerships and are piloting these models, one thing that we've also been focused on, particularly over COVID, and this is where I get to say I love waking up every day and seeing how my work intersects the government affairs side of my role and the community affairs side of my role, is in allowing the work that we are doing around these community partnerships and these smaller models that have proven and shown success, pulling that data together and informing our elected officials, informing stakeholders. And this is where we can move into stronger public and private partnerships, sustainable funding around these efforts, and using the work that we're doing to inform how policy is shifting on the local level. The work and investments that we've made in the digital divide during COVID, the investments that we've made throughout our broader COVID community response. We need to be sharing these stories, talking about this work, and bringing public and private partners to the table to scale, not just within our local jurisdictions, but on a regional and national level. level.
Right.
Joe,
Well,
I'm wondering if I could just jump in here, because as I've
yeah,
listened
absolutely.
to what each of the other panelists have shared, I find myself saying, this is in a purpose-built community at a local level. This is where a lot of those things that each person talked about really comes together. One of the things I didn't mention is that with a purpose-built community, we have something called a local community quarterback. And that community quarterback is a separate 501c3 that really is the holder of the vision for that transformation and also for engagement of community and bringing partners to the table. I heard public-private partnerships quite a number of times. So I just wanted to maybe show a few examples of how some of the things that Alicia, Marissa, and Mary have been talking about maybe show up in a local community. So for example, when COVID hit and we knew that we were seeing these disparities, but we knew a vaccine was on the way. We know, again, for historical reasons, there is hesitancy around medical and vaccines and sort of experiments in the Black community. And so we partnered with Piedmont Health System, one of the health systems here in Atlanta. We brought in the head of the COVID task force, who came and had conversations with community members to help them understand about the process. And then as the vaccine became available, we actually, the community quarterbacks in 3 of the Atlanta neighborhoods, was able to bring a vaccine clinic into the neighborhood so that it helped, so that you didn't have to worry about the transportation to get the COVID vaccine and also testing, as well as seniors that perhaps had difficulty in navigating the systems to be able to get appointments. We reserved particular places for people within the community. So that's, bringing the health system into the community with that partnership. Another example is in Orlando. There's a community called the West Lakes Communities. It's 7 communities. And there's a really unique, innovative partnership that the LIFT community and that quarterback has been able to bring to the community. Advent Health, Orlando Health, and Florida Blue, along with some philanthropy, are creating a health center that is right there in the community. It's probably the first time that 2 major health systems in that community have come together in partnership. So it will have a federally qualified health center. It will have community space with a cafe. You talked about movement, Mary. It will have other community spaces where people can convene. It will have a gym. So what our community quarterbacks try to do in partnership with residents is understand their needs, then figure out who are the partners that can help address those needs, and then try to figure out how do we negotiate that space, whether it's physical or whether it's social cohesion kinds of things that you have to do in a neighborhood to bring innovative solutions. So that's just a couple of how the various organizations that are represented here, their counterparts in some of our local communities, are finding out how do we navigate that and how do we ensure that we bring those healthy solutions to community.
Now, I want to stay with you for just one more minute because Marissa said something, and I saw you nodding your head about listening and about how when you get a developed community, there is going to be gentrification and displacement. I want you to address that question for a minute. I mean, you've talked about the success of some of your communities. The purpose-built community in Atlanta now has a mixed income. It's really difficult to get people to kind of separate that in their minds. How do you do that? How do you get people to buy into the concept without having the disconnect of living in a community that they think is only for those people, but that actually is a quality environment that has a lot to offer for everybody?
Yeah, it's complicated. It's complicated. And I think that is part of where we have been able to be successful. I'll keep going back to our amazing leaders who spend a lot of time in community, listening to what is the vision that the community has for what they want, and how can, maybe they don't have the resources, maybe they've not seen a particular model. How can we work with residents to help them see how they can bring their dreams into the community? Mm-hmm. So that
you're talking buy-in basically.
Commitment, and ownership. It's not just about buy-in. I personally have trouble with that word. It's about how do we create ownership for what's happening in a community, and how do we bring commitment, not only from resources outside the community, but from within the community. I think, that the G word, as I call it, the gentrification word, I will say first, concentrated poverty and under resources has never been a successful model. So when new resources come into the community, we know that it's going to bring changes. And what the challenge is how do you navigate bringing partners in, working together, and bringing community voice to what is needed. Part of what we try to do, and we've learned a lot in the 20-something years that we've been working on this, is, who controls land a lot of times controls the destiny of a neighborhood. So one of the things that we try to do in partnership with community and our partners, as we are beginning to go in and we're beginning to see some of these changes, how do you try to ensure that you can find creative solutions to hold land so that you can keep it affordable, that you can keep legacy residents by helping them rehabbing their house or providing grants to do a number of different things. For example, it's like, I'll go back to that as before I turn it back over. It's been 20-something years. And when I drove to the office today, which is close to the East Lake neighborhood, they're building new affordable townhouses 20 years later because they were able to purchase the land through the philanthropy and partnership, hold that land as the community was changing. And 20 years later, they are doing, I think it's 110 townhouses, 70 of which are affordable and 30% are market rate. That speaks to sort of that long game that you talked about and that long vision of making that commitment, bringing neighbors together to understand what they want and what the vision is, and then being able to develop those public and private partnerships that can help make those transformation. But because we're here for long game, I'm not sure I know too many neighborhoods where you started this revitalization effort and some of the same investors and individuals are still holding the vision for the organization. We're not necessarily perfect, and there's things that we've learned along the way, but without partnership in the way that we have worked with communities, the market's going to come, and it's going to come without a plan. And that's what we really try to engage community to create.
Well, and Mary, I've gotten a couple of questions about your program. And one that I personally have is trust, right? I mean, one of the linking factors in all of this is there's so much distrust in every single system because every single system has had bias incorporated in it to one degree or another. Your organization is coming in and offering something to these women. I'm presuming it's mostly women. Is that correct?
Well, I mean, you can have programs for men too. We just happen to start with women.
Sure.
And because, the people that have a much higher burden of MSK, musculoskeletal disease, are women and individuals of color.
Right. And the question that I have from one of our audience is that he says, as a Latino psoriatic arthritis patient, I've suffered the discrimination of medical providers downplaying my chronic disease and my comorbidities. And that kind of plays into the question that I wanted to ask you about trust, because he has had negative experiences. Other people have had negative experiences. You're coming and offering something completely different. How do you get them to trust you? How do you build that trustworthiness? And where do your clients come from? Are they coming from the neighborhood? Are they being referred by other physicians? How does that work?
So I'll make a couple comments. In terms of our Operation Change programs, we basically invited women from the community, either through reaching out to the YMCA or local churches, or simply putting an ad in a local newspaper if people were interested. So that's how we populated those groups. But the trust issue is critical, right? Whether that's a community group, those women develop trust for each other and the emotional connection with each other. But and I say this as a member of, the healthcare profession, as an orthopedic surgeon, we have failed, in my opinion, in the vast majority in a lot of cases, to really have our patients trust us. And it gets back to the comments that Michelle was making and everybody's making about partnerships. Yes, we need partnerships, but we need partnerships in the delivery of care between the healthcare provider and the patient. And part of that means engaging them in ways that acknowledges who they are and what matters to them. And I'm just going to share with you one of the other tools that we developed. It's called our shared decision-making tool. Michael, if you could just put it up briefly. And this tool is very unique because it takes into account an individual's gender, race, ethnicity, their weight, some comorbid factors, and then what the tool inputs. And I'll just focus on the top section, which says knee pain. So this would say to this individual, in this case, it's a 67-year-old, I think I can read that, African-American woman, okay? And her knee pain is 5 today. And if she does nothing, you can see, do nothing, that her pain is going to progress. Her function is also going to get worse, okay? We don't often have conversations with patients. If you do nothing, here's what will happen. And we created this tool with some really smart people at the Bloomberg School of Public Health at Johns Hopkins. If you do the middle intervention, increase your activity, weight loss, over-the-counter medication, look at the dramatic improvement in her knee pain. Okay, wow. And of course, with time at year 6, it goes back up. But she can be feeling much better and more active, have better function. If you go down on the second line, the functional level is much better. And so we also can compare it to, well, if you get physical therapy and cortisone shots in your knee and you take prescription medication, then we can help control your symptoms that way to some degree as well. Thank you, Michael, for showing that. So it's really, how do we develop the partnership with the patient and show them, not in a judgmental way, okay? Not in a way that says, you're somehow a bad person because you're not losing weight and you're not increasing your level of physical activity, right? It's, how can I show you why it's so important to you to embrace better health?
Which is interesting, because that's so often what I hear when I write stories about bias. And I wrote a story maybe a year and a half ago about how someone who is overweight comes into a doctor's office and gets a lot of judgment and not a lot of explanation. And that in turn causes a barrier between the person and the doctor. They're hearing one thing, the doctor is trying to express something else, but if it's not expressed in either a culturally sensitive manner or a sensitive manner in general, the message tends not to get through.
So one of the things that I love about our tool is that it's personalized. So that patient, whether it's a Caucasian woman or an African-American man or a Latino woman, right? I mean, we're saying here is the data based on people who look like you, right? Not comparing you to the affluent white male CEO, for example. I'm comparing you to people like you and see what a difference this can make. And so now let's get to what Alicia mentioned. What are your barriers? How do we support you with your barrier, with addressing the barriers that you have to adopting healthier behaviors? Because if we don't get a handle on improving the health of our communities, I really don't know what the future holds for us. We can't afford the rising healthcare costs. Obesity is a pandemic in this country, okay? I don't know how we're even going to function 10 years from now with the long-term effects of lower rates of physical activity, obesity, and joint pain. So we need to get upstream on this. We need to engage patients to adopt healthier behaviors. We need to support communities that facilitate those behaviors. And we need health systems. I'm covering everybody's base here, right? And we need health systems that recognize the importance of equity and meeting communities where they are.
Right. And that brings me to you again, Alicia. I mean, Mary is she's talking your language, it seems. And That's very much where your space is. But I also have a question from the audience that says, what metrics would you focus on in trying to measure progress? That's number one. And number two, the question was about health literacy in terms of electronics. One of the things that COVID has changed is the fact that we can do visits remotely, which is a boon for some, like myself, but a hindrance to others who don't have web access, who don't have high-speed broadband. And I guess that question spills over to what Michelle talks about. So I want to see if you can address the first part of the question, Alicia, and Michelle, talk about the second one. And Alicia, if you feel like you've got some answers for the second part, vis-a-vis broadband and telehealth, go ahead and lay them on me. Tell me what you think.
Yes, thank you, Joe. So I'll speak specifically to healthcare delivery systems as it relates to some accountable measures or metrics. I am really, healthcare is so fragmented in this country. And I think we do need to be careful that we don't create another silo of medicine around equity or around social determinants of health. Really, how do we, again, embed this principle across systems that are already in place? So for example, most of us as healthcare providers have some sort of quality improvement infrastructure in place because one, we're required by certain national organizations. But ultimately, if you're trying to drive health outcomes, you want to monitor your success. So we're looking at things like diabetes control, high blood pressure control, readmission rates, sepsis rates. I mean, there's so many different quality measures that we already review on a regular basis. Are we looking at that data by race, by ethnicity, by gender, by sexual orientation, by social vulnerability index scores? I mean, there's so many different ways to stratify data. And are you consistently building that into how you look at the data that you already have? So for example, how do you know if you're able to, or where you should target some of your quality improvement projects if you're not looking at it in those ways? So that's the first thing I would say. And this goes across, regardless of if you're a healthcare system, a housing system, an education system, are you consistently collecting data around, at minimum, race, ethnicity, language, sexual orientation, and gender identity?
Let me stop there for a minute. Is that unusual to not have that data collected?
Well, I think COVID showed us that, right? I mean, let's just be honest. There is, as of right now, there is no national requirement to collect that data. There are national guidelines and recommendations, but there is no requirement. There are some states that have that requirement. So for example, California, we are required to input that data when patients come through our hospital systems. But that is not something that's consistent or standardized across our entire country. And again, I think COVID very clearly showed that as we started to want to look at the data that way, how many states were like, we don't even have that data.
Yeah,
right?
which I guess is probably another, put that in the pile of, another kind of system that race is kind of not really accounted for. But anyway, continue.
Exactly. So that's just a minimum, like that. If your organization is not looking at the metrics that you're already collecting for your process improvement, quality improvement, and looking and stratifying it by that, I won't say it's an easy place to start because it sounds easy, but it's actually hard to do. But that's a great place to start. And then the other thing I would say, just quickly to the digital divide question, we actually had that question, health systems had to pivot pretty much overnight when COVID hit to providing care virtually, which we were really excited about because we've been wanting to provide care.
Yes,
I think that can actually really address some of our access issues, especially in our rural communities. But going back to systems, we didn't have payment for that. We didn't have resources to support that kind of infrastructure development. And, I do think if you look at some of the positive things that have come out of the pandemic, and when we go back and do our deep dive on this, I think this is going to be one of those positives, that it really pushed our healthcare delivery system to embrace telehealth and really improve access. But to that point, we want to make sure that we're not unintentionally widening disparities. And so one of the things we looked at again was, well, what is the demographic breakdown of our patients who are participating in telehealth visits? So adding that, again, that measurement to it, being able to see, well, wait, in this market, we're seeing, maybe African Americans aren't engaging as much as they are in this market. And let's see, what are some best practices? Is there something that this market is doing differently to engage with that patient population? And then sharing that. That's one of the things I do love about being a part of a large system, is that we can identify best practices, share and scale, fairly quickly. So that's one of the things. And then the other thing, one of the programs that I have responsibilities over is in our maternity space and our healthy birth outcomes. With a patient navigation tool, we used a technology vendor, Docent Health, to navigate our moms during the pregnancy, especially with COVID. And we actually went with Docent Health because they were a text messaging based solution. I think when people think of telehealth, they immediately think of like virtual visits, FaceTime, Zoom. You need to have a smartphone, you need to have an app, you need to have, well, no, it can be as simple as picking up a phone. It can be a text message. We actually went with the text messaging solution because we knew that majority of people in this country do have the ability to text and have access to some sort of texting capability or phone. And what we have seen, we added a health equity framework to that. So what we are seeing is consistently higher engagement rates. Actually, overall, we've had a 68% engagement rate of moms with this program, but higher than that, over 70% engagement rate with our women of color.
Wow.
And we're connecting that, which you just don't see, especially in virtual navigation platforms. So we're that's very, very preliminary. We're looking to hopefully publish this information soon, and we're tying that to birth outcomes, right? So, we're looking at preterm birth weights. We saw in our pilot a 37% reduction in women who were engaged with this navigation service who had Medicaid. So a 37% reduction in preterm birth weights. We're looking at C-section rates. We're looking at breastfeeding initiation. So again, even how you communicate with your vendor partners and, talking to them about, we want to embed health equity framework into this relationship. And so how do you do that? So I will leave it there and let Michelle jump in here on more of the digital literacy.
Yeah. So I think there's, there's so many things that you touched on. And I think where a lot of our communities have been focused is, number one, creating access to technology and to the internet. So particularly during COVID, we have been doing a lot of distribution of whether that's a Chromebook or it's laptops, so that people, one, have a device and have an internet connection to be able to take advantage of some of the things that Alicia talked about. So, that's sort of on the shorter term kind of issues that we're focused on. But one of the benefits about being a network, we are able to come together in those 28 locations and say, where do we have similarity in terms of challenges that we're trying to address? And one of them is the digital divide and digital literacy. So a lot of times philanthropy helps our community quarterbacks be able to bring some of that into community. But also as a result of, in a time of COVID, we recognize that there's power in that community. And so we have created a community of practice around the digital divide. And one of the things that we're focused on is there's a lot of different ways that you can bring digital technology and access into community. What if we began to think about the way we develop housing? And particularly affordable housing and multifamily housing. What if, as part of the development, you did a better job of embedding the capability as you're thinking about what families need? How do we think about various?
Every house comes with Wi-Fi, you mean? Or every house comes with Wi-Fi?
Yes. How do we think about that? How do we think about communal spaces that give people access to the internet and to some of these applications? And so we're spending time thinking like, what are a few of the scenarios that we can really think about, and what are the policy implications of that, as well as working with providers, whether it's the healthcare provider or it's the internet provider, to think of a solution, and then also think what are the policy and the practice changes that have to happen to provide that access. And so that is really getting geared up as a result of what we've seen in COVID. And I think the thing that I want to articulate is some of it is individual. Like you said, I'm a patient. I need to be able to have access to telemedicine, perhaps. But it's also about that infrastructure, not just for me personally, but in my community, so that I truly have access and I can afford it. And what are the policies and practices? Neighborhood work is very important, and you've got to understand what's happening on the ground. But then you also have to be able to translate that into a bigger system, right? And to what are the policies and the practices that we as a country or my state can think about differently to be able to get us these challenges.
Well, I have one really quick follow-up for you, and then I want to move on to Marissa, because I have a question for you. The first follow-up I have is for you, Michelle, is you talked a lot in your early presentation or your early remarks about how things have gone from an economic standpoint. Like you have people graduating from high school, going on to college. You have a community that's vigorous and has more people of different economic strata in it. Talk about health. Have you been able to show any metrics on how living in a healthy community has actually improved the health of the residents?
Yeah, so there's a lot of research to back that, and we have seen, I'm not sure that I've got the specific metrics for each community, but for example, in the North Side community in Spartanburg, they're partnered with a health partner, and they bought a clinic there. They have been able to bring down some of the issues that Mary's been talking about in terms of chronic diseases. I don't have necessarily the specific percentages, but in each of our communities, that's one of the things that they look at, and they have a scorecard to be able to say, how are the health outcomes actually progressing community by community? So yes, we are seeing that the health is improving, and that's one of our long-term metrics. How we look at that over the life of the entire sort of initiative, we're actually beginning to think more deeply about that, but on each community basis, they have their own metrics for the types of things that they're wanting to see in terms of health improvement.
Well, and I'm getting the signal from Michael, so I may not be able to get to the last question for you, Marissa, but I wanted to give each one of you an opportunity in like a minute or so to talk about what you hope to see in the coming year. We've had a year, George Floyd is a year in the rearview mirror right now, and we're moving on from there. And I'd like to know, you all talked about that this is a long-term process that is going to take a while, and that the gains that we've seen over short term, may not necessarily be as satisfactory, but it points us that we're in the right direction. I want each of you to tell me, in a minute or so, what's positive. Tell me something good. Tell me what you've seen and what's going on that is moving us in the right direction post 2020. Start with Marissa.
I think philanthropy. Philanthropy has done so much important work through COVID in allowing us and our counterparts within other states and systems to do this important work. What I want to see is more of us stepping up to the table. We need systems to invest more resources. We need to shift our community benefit spend to align against these priorities. We need more investments that are government funded and backed, and really just leveraging of resources to move this work forward in a scaled way.
Okay, that's very optimistic. Alicia, take a stab at it. Tell me something good that we can look for in the next year.
Well, I think one of the great things that has happened over the last year with the pandemic, with the George Floyd situation, is that there's a lot of wokeness right now. Everyone's woke, and I think that's important. I think that's really important. I challenge us to stay awake, and so I think as you are thinking about what you can do as an individual, all of us have an opportunity One of my favorite quotes from Arthur Ashe is start where you are, use what you have, and do what you can. So we all have an ability to influence people and help people as it relates to the inequities that we see, not just in healthcare delivery, but across our entire system. But just think about what more we could do, how much more impact we could have if we were really working together to really, eliminate these disparities. There's no reason that our country is not in the top 10 for health outcomes across the world. We're in the 30s, low 30s, actually. And so part of the reason
that's a whole other program. That's the next program we're going to take a stab at.
But part of the reason that exists is because we allow these disparities to continue to fester in our country. So, I'm really excited about the level of wokeness right now. I just encourage us all to stay awake and each of us to do our part to eradicating disparity. Stay
awake, cup of coffee all around. Michelle, your turn. Tell us something good.
Yeah, so I'd plus one Marissa and Alicia's comments. I think there's some funding that's coming out of the federal government that will connect with philanthropy. So I'm encouraged by that. I'm also encouraged that health systems are thinking about how they really engage with community. And I think a lot of this is sort of put the disparities that people already knew on Front Street, and that putting it on Front Street is requiring big systems to think differently. But the thing that I will add, again, going back to that community perspective, is that community is awake. And where perhaps people in community didn't feel like they had a voice, maybe didn't have a partner, I think they're demanding more. And they are going to be holding systems and philanthropy more accountable and are willing to put their voice out there and to be heard. And I think that bottom up and hopefully, partners together can create something that perhaps we have not seen before. So I'm excited about community.
So community on Front Street, we've got an opportunity for change here. And last but certainly not least, Mary, tell us what you think. Tell us something good.
So Joe, I will plus one all of this and say, movement is life. We have been in this disparity space going on 12 years now. And it's like now with the pandemic, all of a sudden we have awareness, wokeness of these issues. Okay, we must continue to seize them, to keep the momentum up. One of the things that I feel is a positive that it came out of the horrible outcomes of the pandemic was a recognition not just of the disproportionate impact in our underserved communities and communities of color, but higher levels of comorbid conditions in those individuals.
It's not just one thing.
It's not just one thing, okay? And we tend to want to look at things in a very simplistic, way, and it's just not simple. And so looking at recognizing that these comorbid conditions, you may remember early in the pandemic, it was, okay, your risk of dying is greater if you are diabetic or if you're obese, and people started to look for all these risk factors. Well, then let's intersect that with who is getting sick and dying of COVID. We know who it is, okay? Individuals of color, disproportionately impacted. So this greater awareness is critical. I also see advancements on the policy side, because you remember I showed that public and private policy ring around the social determinants of health. So a few years ago, we engaged with the great late Representative John Lewis in discussing payment policies, that unintended consequences of the Affordable Care Act relative to the Center for Medicare and Medicaid Innovation. I'll just translate quickly for listeners who may not be familiar with this space. It's basically the government, Medicare and Medicaid, can introduce new payment models that would be able to be operationalized as pilots as long as they did not drive up costs, they lowered cost, and they maintained quality. But they didn't look at access and they didn't look at disparities. And we know that some of these payment models basically promote cherry picking of healthy patients and lemon dropping of unhealthy patients. And we all know which demographics fall into the unhealthy group. So we worked with Congressman Lewis. He created and submitted the EMMT Act, the Equality in Medicare and Medicaid Treatment Act. Unfortunately, we all know he passed. That is now being reintroduced or will be reintroduced, I believe, by Senator Cory Booker. And we're really hoping that we can get on the policy side some support to get this change in terms of the way CMMI reviews programs, because the legislation would require them to also take into account the impact of a new payment model on health access and on health equity. And we certainly need that. So I'm optimistic that we're going to get that legislation through.
Well, there's a lot ahead of us, and hopefully we'll be able to discuss more of it in the future. It was a wonderful panel. I thank all of you for participating. It's a very powerhouse, accomplished group of women that we've had here today. I want to say thank you to Dr. Mary O'Connor, who's Chair of Movement of Life and Chief Medical Officer for Vori Health. Marissa Mckeever, she's the Director of Government and Community Affairs for Sibley Memorial Hospital and Johns Hopkins Medicine. Michelle Matthews, Senior Vice President of Purpose-Built Communities in Atlanta. And last but certainly not least, Alicia Cole, the Assistant Vice President for Population, Community Health and Policy for CommonSpirit Health. Thank you all very much, ladies. I really appreciate having you on, and hopefully we can have you back again soon. Take care. My name is Joe Williams, and we'll talk later.
Thank you. Thanks, Joe.
Thank you.